let's continue on with the arthritis component and go to Takayasu. So Takayasu classically presents in an Asian female in her 4th decade, so she's maybe 30-ish to 40-ish, and has unequal pulses in the upper extremity, so UE, myalgias, so joint pains, muscle pains, and skin nodules, in addition to fever. Maybe a little bit of eye involvement. We always classically see some sort of ocular disturbance or problem. Now, let's think about why. So the problem here is, again, it's an antibody-mediated damage to structures that are coming directly off the aortic arch. As you can see, there's some sort of nodularities going on, fibrosis, there's a very constricted segment here, and then you see that there's this uneven edge that you would expect from a normal-looking right innominate or left subclavian. In addition, you can see some sort of irregularities here in the common carotid branch that's coming off of this aortic arch. Again, this is our aortic arch. So you can see there's some sort of catheter or structure in there. Now, the problem, again, is that there's aortic arch involvement in great vessels with continued inflammation and thickening. So there's some sort of inflammation that leads to healing with fibrosis. And this has also some sort of contracture-like component on the lumen of these vessels. As you can see, this is a very smaller diameter compared to this one. Now, when you thicken the wall, you decrease the diameter of the lumen. So if we go from this to this, what do we do for blood flow? Is that good for blood flow? No. This is the concept that you need to think about in Takayasu arthritis. When you damage the vessel, cause a decrease in blood flow to end organs due to this fibrotic-like process of repairing an inflamed vessel, you cause ischemia of those tissues because they have decreased blood supply. So the deposition of antibodies in the media leads to granulomatous inflammation and the presence of giant cells from the fusion of macrophages. And this is very similar to the other large vessel vasculitis, which is the temporal arteritis, in which you also see giant cells due to the fusion of macrophages due to continued chronic inflammation. Now, the damage from inflammation can eventually weaken the elastic lamina and media. So remember, these antibodies are depositing in the media, and we have 3 layers to our vessel. So this is the intima, and then it sits on the internal elastic lamina. Then it's the media. So remember, the damage from the inflammation can eventually weaken this elastic lamina and the media. In addition, there's an external elastic lamina here that separates the adventitial layer from the medial layer. So again, we weaken the media and the elastic lamina, which means that we weaken our vessel wall. So the strain of the artery is within the lamina and the media. And by destroying it in Takayasu arthritis, we set ourselves up for weakened vessels that can balloon out and get aneurysms. And this is very important to notice. In addition to knowing about the association with aneurysms, we need to know about a treatment plan. And the treatment, just like with temporal or giant cell arteritis, we treat with corticosteroids. So let's quickly review the difference between giant cell or temporal. Remember, both of these have giant cell components because it's chronic inflammation that causes fusion of macrophages. So the temporal cell arteritis versus the Takayasu arthritis. Important to have in your mind is 2 distinct separate entities. So both of these are large vessel vasculitides that will present with both increased ESR, possible vision disturbances, and both have systemic cytokine-induced symptoms such as fever and joint or muscle pains. And both of them are treated with corticosteroids. So the treatment is corticosteroids. So a lot of things in common, right? But a lot of these are just due to the fact that there's inflammation, which means an elevated erythrocyte sedimentation rate, fever, joint muscle pains, and the treatment's obviously corticosteroids because it's a hyped up autoimmune response. And the vision disturbances again come from the fact that giant cell or temporal arteritis can involve ophthalmic artery, and so can Takayasu. So what are the differences? Well, again, Takayasu is referred to as the pulseless disease, and these classically affect the branches of the aortic arch, which are the left subclavian, the common carotid, and then the right innominate. Remember, the right innominate gives rise to the right subclavian and the right common carotid, as opposed to this is just the left common carotid extending. So that fibrosis of the aortic arch branches are more proximal in Takayasu, which means that if there's obstruction of the left subclavian and this one is still slightly patent, or they're both fibrotic and the lumen is narrow, there'll be a decreased pulse sensed when you grab someone's wrist and check their radial pulse in the radial artery. So a left subclavian branch that supplies the left upper extremity and the right brachiocephalic or right innominate giving off the right subclavian and the right common carotid. There can be changes in people's pulses with Takayasu arthritis. Again, classically giant cell, you have an elderly female, while this is most likely an Asian, middle-aged female, 30-ish, 40-ish. So this is some of the high-yield information that you definitely need to have in your mind. Both of these giant cell arthritis, both of these large vessel vasculitides are important. So, let's do a flash quiz. Here it is again, snuck up on us. A 75-year-old woman presents with new onset jaw pain and headache at the right temple. Now, what is the most likely diagnosis? The most likely diagnosis is temporal arthritis. Again, we have a 75-year-old female, so classically elderly female, jaw pain, headache in the right temporal region. The most likely diagnosis, or what we should be thinking about on our differential, is temporal arthritis. Now, polyarthritis nodosa is a very diffuse vasculitis, and that is reflected in the name. Poly means many, so many arteries. Arthritis again indicates inflammation. Many arteries have focal inflammation within them. So if you imagine a large segment of an artery, there could be a little inflammation here, a little inflammation here, and here, and here. And this can occur in any artery. Now what about the nodule part of the name? Nodosa. Remember how we said that when we cause damage to the media, when we deposit antibodies there, again this is an autoimmune vasculitis, we're depositing autoantibodies in some sort of vessel. So we damage the media and the laminae that hold together the artery. So these are blasted out. Now what's happening in this disease is that we're causing complete or transmural damage in random segments all along the vessel wall. And this can lead to the classic string of pearls appearance on some sort of angiogram or any sort of imaging that allows you to see specifically the unique structure of the vessels. So what actually this presentation is a microaneurysm seen on our arteriogram. So if you imagine here's a little ballooning out, and here's a little ballooning out, here's a little ballooning out, and this is the classic string of pearls appearance because there's a microaneurysm here, and here, and here, surrounded by normal segments of the wall. So it looks like a necklace made of pearls. Why else should we worry about damaging these medium-sized vessels other than the fact that we get aneurysms? Well, they are particularly important because if you mess around with the organs that medium-sized vessels supply, it can be a serious problem. So what are some of those organs? How about stuff in this splanchnic circulation? So a lot of splanchnic vessels can be involved, and you can get ischemia of the intestines, and this causes anginal-like pain of the intestines. Remember, this is just smooth muscle and it's slightly ischemic. So, stomach pain. You can also have a patient presenting with a more complex situation in which they have this stomach or abdominal pain in addition to dark tar-like melena, so a very dark tar-looking stool. And that just means that there is bleeding within the stomach and it presents with very dark oxidized-looking stool. In addition to the splanchnic involvement, we can have renal involvement. So blood supply to the kidney can be compromised due to constant fibrosis and deposition of antibodies in these segments. We narrow the lumen due to healing with fibrosis. Despite having some aneurysms, the overall process is that we're decreasing the caliber of these vessels because there's nodules of inflammatory fibrotic tissue distributed all throughout the vessel. As you can see here, there's a lot of inflammation, a bunch of inflammatory cells in this component. And then here's the lumen, and it is being pushed together. So if you have this happening in places like the renal arteries, they have very low perfusion pressure, and this leads to the activation of the renin-angiotensin-aldosterone system, because the kidneys do not like being hyperperfused. We know very well that the kidney is a very stubborn organ. It will respond to low perfusion by activating the RAS system. Chronic renal responses to vasculitis-mediated hyperperfusion can eventually lead to hypertension, which comes along with headaches. There is an association here with hepatitis B. So Hep B is a very high yield fact to know about polyarthritis nodosa. This gives me a link to another high yield subject about microbiology. There is an association with hepatitis B because patients with Hep B induce an immune response to viral proteins. So they end up forming immune complexes composed of an antibody to the hepatitis B virus, and we have complexes formed that will circulate and deposit within the body tissues, particularly in medium-sized vessels like this flank circulation and the renal vessel. So 30% of these patients are actually seropositive, or if you test their serum, they'll be positive for hep B surface antigen, so surface antigen and surface antigen antibody. So SA denotes surface antibody, and SAAB is surface antigen antibody. You treat them again with corticosteroids because you want to stop their immune system from continuing to pump out these antibodies and having the subsequent immune complex deposition. So if you blast them with corticosteroids and corticosteroids still don't get the job done, you can actually switch to more aggressive immunosuppressive agents, such as what? Cyclophosphamide. This is a direct alkylating DNA agent, so that is another way that we can suppress the ability of the immune system to generate these antibodies that are creating immune complexes that are circulating in vessels around the body. What about Kawasaki disease? So this poor little fellow here has another type of medium vessel vasculitis. I don't like stereotypes, but Kawasaki definitely sounds like an Asian name. So your patients classically present with fever, cervical lymphadenopathy, so C is for cervical, LAD is lymphadenopathy, conjunctival injection, or very, very red eyes, and also a look that they are very watery, and a red desquamating rash on the palms and soles, in addition to mucocutaneous involvement, so mucous membrane involvement, and skin involvement that includes the definition of a strawberry-like presentation of the tongue, and also very, very red lips. This is the mucocutaneous involvement, again also including the conjunctiva. So if you see any of these things in this combination in an Asian kid who just happens to be around the age of 4 years old, you definitely need to be concerned. Why? The reason why is in this image, right there circled on the middle of the diagram. This is a radiograph showing you one of the potential complications, and that is involvement of the coronary arteries. So if you damage the coronary arteries, you can cause them to balloon out in little aneurysms. As you can see, this is a coronary artery aneurysm, and then here, in addition, are also some other dilated vessels. So this is a really bad situation. You need to immediately give your patient aspirin to prevent any thrombogenic progression within the coronary vasculature. I know what you're thinking. Give a kid under the age of 4 aspirin? And he's Asian? How racist can we be? No. This is just classically seen in the Asian population, and we need to give aspirin because there's a risk of exposure of subendothelial collagen and von Willebrand factor, which will trigger the formation of a platelet plug. Aspirin will irreversibly inhibit cyclooxygenase enzymes, which helps prevent the progression of any platelet aggregation because by inhibiting cyclooxygenase, we decrease the levels of thromboxane A2, which is a very thrombogenic modulator. Here is a classic image of the strawberry tongue that you'll see. So the deposition of antibodies in highly vascularized networks such as the lymph nodes, the conjunctiva, the oral mucosa, the arteries of the palms and soles, in addition to the inflammatory component of redness, edema, and potentially desquamation and rash in these areas gives you a lot of the physical signs and symptoms of a Kawasaki-like presentation. This is a particularly high-yield fact because it shows you how there is a mucosal involvement of the tongue in addition to the perioral area. Not many situations should make you think about this. The other one that we talked about was the scarlet fever that had a very dark red looking tongue. So when you hear about a kid who has a dark red tongue with some other type of mucocutaneous involvement, you should be thinking about scarlet fever and Kawasaki disease. Remember that the big difference is that scarlet fever does not have any sort of palm and sole involvement. There's no desquamating rash, as opposed to Kawasaki disease where there's a lot of involvement of the palms and soles, and you need to see them actually peel skin off of their hands and feet because it is just desquamating due to the damage from the vasculitis. So let's talk about Buerger disease. This is also called thromboangiitis obliterans. So the name thromboangiitis obliterans really tells us a lot instead of Buerger disease unless we knew the guy personally. So what's going on in this disease is that there's some sort of thrombus happening in this vasculitis. And there's also angiitis, which means inflammation of the vessel, and causing some sort of obliteration of whatever structure we're talking about. Since we're in the vasculitis section, there's probably obliteration of the vessel. And that is exactly what happens. There's obliteration of the vessel lumen. If you completely occlude the lumen from here to here, because we have obliterated the lumen, then there will be a high level of hypoxia and ischemia and infarction of whatever tissue is downstream from it. There will be no blood supply or oxygen supply. They will become ischemic and result in eventual necrosis. And the complete deprivation of blood due to occlusion of vessels, such as in the digits or skin, can lead to autoamputation, because we're essentially cutting off the blood supply to our own fingers and toes. The superficial nodular phlebitis is due to thrombi blocking the venous circulation. This means blood stasis. So, if you have a thrombus in a vein, there's no flow of the venous blood. There will be engorgement of this vessel, and it will get very inflamed and irritated. And this causes a pressure-like ulceration of the superficial veins. We call this superficial nodular because there are nodules due to the engorgement of this vessel and inflammation that it presses on the skin above it. And this causes a superficial nodular-like presentation on physical exam, and we call that superficial nodular phlebitis. And how does all of this start? Tobacco. The patient is usually a male smoker, so male smoker, usually 4th decade, that's been having some sort of severe pain and color changes in his digits. Kind of sounds like Raynaud phenomenon, but the element of pain is the concerning part. And one of them may be even described as looking slightly necrotic. So think about this Buerger disease or thrombomeningitis obliterans as an abnormal response to tobacco by the immune system. The immune system actually starts producing anti-endothelial cell antibodies. The antibodies bind to what? Well, they bind to endothelial cells lining whatever vessel you want to be worried about. So in this position, when we worry about the superficial nodular phlebitis, there is obliteration of those vessels due to liberation of the contents of endothelial cells when antibodies bind and activate complement, causing endothelial cell dysfunction and damage. So the exposure of whatever contents of these endothelial cells might be, including von Willebrand factor and claudin factor 8, leads to the formation of a thrombus. In addition, we can damage the subendothelial collagen under these endothelial cells and really kick off this cascade. Now this occurs in random segments along the vasculature, which again, this is referred to as a segmental thrombosing vasculitis. The only targets of these autoantibodies are the endothelial cells lining the small vasculature of the fingers and toes. These antibodies bind endothelial cells and cause an infiltration of inflammatory cells with subsequent destruction of endothelial cells. This creates a humongous obstruction that pushes inward towards the lumen, and this will eventually occlude flow. Now, what is the treatment for this disease? How about Xing out the cause? Stop smoking, patient. Please save your fingers, save your toes. So let's summarize Buerger disease. It's an antibody-mediated vasculitis, the production of anti-endothelial cell antibodies that damage endothelial cells, leading to endothelial cell dysfunction and acute formation of thrombi within the lumen of vessels. This also comes with impaired vasodilation. This leads to decreased O2 delivery to tissues, particularly the fingers and toes, and this leads to autoamputation. Infarction of the small vessels that supply the nerves of the upper and lower extremity can present as painful claudication.